Kia ora, welcome everybody. I can see some people streaming in, some of the viewers coming in. Tēnā koutou. We are going to get straight into this. No reira, no mai haere mai. Kia ora, ngā mihi o te ata kia koutou katoa. No mātou I konei I a toi tangata kei tāmaki makaurau. Tērā pia te ahua pito o tēnei wāhanga o te motu. No reira, no mai hoki mai ki tēnei āhuatanga o toi ako. He momo kōrero tēnei, kia tae ai ngā rangahau, ngā kōrero, ngā mahi o te maria, kia puta ki te hunga whakapiki hauora. No reira tēnā koutou. Kia ora, welcome to this Toi Ako webinar, a really great opportunity where we get to share ideas, movers and shakers, lead facilitators and researchers throughout the motu. So welcome to this opportunity. We have a really exciting project this time to be discussed from the He Pikinga Waiora team. And I'm not going to take up too much time, so instead of talking about them, I'm just going to briefly introduce from Waikato University. We have Maui, Hudson and John Oetzel. I hope I've said that accurately. From the Waikato District Health Board, we have Nina Scott coming in. From Christchurch at the Institute of Environmental Science and Research, we have Jeff Foote. And finally, from the National Institute of Demographic and Economic Analysis, we have Moana Rarere. So, kia ora, no mai haere mai ngā kai kōrero. Welcome to the speakers, facilitators. Let's get it underway.
Kia ora kariata, ngā mihi kia koe, koutou toi tangata I whakari te tēnei wāhanga. Ngā mihi hoki ki ngā tangata e whakarongo mai nā no reira tēnā koutou katoa. My name is Maui Hudson. I'm one of the co-leaders of this He Pikinga Waiora team, and our project is really about making health interventions work in Māori community. So there's the 5 of us that Harriet introduced. They're going to be part of the presentation this morning. Jeff's going to kick in more around the questions and answers part. So we're hoping to go for around 30 minutes through this presentation, give you an outline of what we're up to, and then hopefully answer some queries that anyone might have. So move on. So we'll get all the technology sorted. Here we go. Excellent. So just as a general little bit of an outline, our project is funded through the Healthier Lives National Science Challenge, and you'll see here a general overview of what that looks like. The science challenges themselves were designed to try and get people collaborating more around issues of significance to the country. And certainly in terms of reducing the burden of non-communicable diseases, in particular cardiovascular disease, diabetes, cancer, and obesity, that's been the focus for this challenge. So you'll see here that part of the challenge is around having healthier lives for all New Zealand, part of the vision for the challenge. The mission is the right prevention for the right population and the right treatment for the right patient. One of their key targets has been around reducing inequalities. And while that will involve getting better treatments and earlier diagnosis of non-communicable diseases and also helping prevent them, there's also a focus on activating communities and more community involvement. And how these challenges came about was really different researchers getting together to decide what was the kind of key areas and things that needed to be worked on. So some of the people that got involved started thinking about what is the challenge of implementation. So a lot of things that happen in the research space, there's a lot of interventions that are worked out, which are effective in a research setting, but then when they're shifted into kind of the real world, they don't do as well. Also, we have interventions that are put together that don't do as well when they're put in an indigenous or Māori community than they do in the rest of the population. And so, we're really interested in what are the things that can be done to make sure that these interventions are as effective for our communities as they are for everyone else. One of the other challenges that often there's interventions that have been proven as being effective, but they're not taken up by the people that provide the funds, or not supported by the people that provide the funds. So often, our communities are missing out on something that could be beneficial to them. So given that it was a science challenge, there's often a big focus on kind of the geeky science part, the stuff that you do at the bench top, that kind of end. But often that's not going to make as much of a difference for our community. So we gravitated to this idea of implementation science, and it's something that's becoming more accepted internationally as an important area to think about. And it's really understanding why implementation of intervention succeeds or fails, and really helping translate all of the resource and intellectual energy and time and ideas that goes into the research space and make sure that it translates into practice. It hasn't, in the past, it hasn't really been focused, there hasn't been much focus on the specific Indigenous angle to implementation science or implementing interventions into Indigenous communities. But we did gravitate to this one systematic review that was done by some colleagues of ours in Australia that looked at enablers and barriers to the implementation of primary health care interventions for Indigenous people with chronic diseases. And that gave us a little bit of a steer. It's probably the first paper that specifically started looking at this area in an Indigenous context. So our team wanted to start thinking about this in the Māori context in particular. We all know the statistics in Māori communities and other Polynesian communities in New Zealand aren't so great, and we tend not to do so well as everyone else in the population. Often in terms of access to services, but outcomes as well. And those are the sorts of inequities that we really think need to be addressed. So this fantastic team that you'll hopefully see in front of you at the moment are all involved in this exercise to try and start working through what Māori, or implementation science for Māori looks like. Here we've got people from a range of disciplines, people that come out of management, public health, kaupapa Māori evaluation, people from community organisations who do systems thinking. So it's really a broad church of people that are interested in really just making health interventions work for Māori. So that was my little bit of the intro, and I'm now going to pass you over to Professor John Oetzel, one of the other investigators on this project, to carry on the next set of slides.
With me is Moana, Rarere, and Reila Gilbert. Reila is one of our community researchers with Te Koha Health, one of our partners, and we'll talk. Nina is going to talk a little bit more about that in a little bit. Moana and I are going to talk about our particular framework. Our focus was on, as Maui said, on implementation science for Māori. And our goal was to use theory and research, international research, to identify a framework that would help address some of the enablers and barriers to effective implementation of non-communicable diseases for Maui. In particular, we wanted to center our framework around kaupapa Māori or Maori self-determination. But we also wanted to be open to the international literature and some of the other concepts that have consistency with kaupapa Māori. And so that's what we were trying to do, is create this best practice model. And so what we're going to do is discuss this framework and go over some of the specific elements. So this is an overview of our framework, a poster that we created and Nina's presented earlier. As I said, it's centered around kaupapa Māori and Māori self-determination. And we recognize the importance of kaupapa Māori for Māori communities. And at the same time, we recognize that there is international literature with Indigenous communities and with other communities that have addressed similar issues around health inequities, around activating communities, and that we wanted to borrow that. So our goal was to try to create a balance between using the international literature and making sure that it was consistent with Kaupapa Māori. So that's where this framework comes from, and it includes, as I said, Kaupapa Māori at the center, but the concepts of cultured centeredness, community engagement, systems thinking, and integrated knowledge translation. We're going to take a moment to talk about each one of these. I'm going to let Moana talk about Kaupapa Māori next.
Kia ora, thanks, John. So this project, the overall aim is to make health interventions work specifically for Māori communities. And so Kaupapa Māori, as John mentioned earlier, is critical to the successful implementation and to reduce health inequities. And so this framework has Indigenous self-determination at the core. And so Indigenous academics, activists, researchers, theorists all agree that Kaupapa Māori places emphasis that Kaupapa Māori places emphasis on the local context, as well as prioritising Indigenous history, Indigenous development, and Indigenous aspirations. And a number of scholars locate Kaupapa Māori in the critical theory space with its notions of critique, resistance, struggle, and emancipation. So it's important that Kaupapa Māori, that this framework is reflective of the importance of tikanga and mātauranga in relationships that form the basis of both community action and community control. And Graham Smith expresses this quite nicely, placing an emphasis on the need for Kaupapa Māori principles to be active to be in an active relationship with practice. So in other words, it's about activating Kaupapa Māori principles in the way that we do things. So if we go to the next. So one of the elements, cultural centeredness, reflects some of these Kaupapa Māori principles. So the aim of cultural centeredness is to transform social structures surrounding health by having conversations with community or cultural members. And so it's about creating a space for their voices to be heard. And there's three characteristics of that underpin cultural centeredness. The first one is about community voice. And so that's allowing the community to participate in defining the problem as well as developing the solutions. The second one is about reflexivity, and that recognises and challenges the unstated or taken for granted power and privilege of outsiders. And it also means for them dealing with that. And so structural, the third one, structural and transformation and resources, highlights the capacity of communities to participate in processes of change on the basis of co-creation.
Right, thanks. Thanks, Moana. Our next element is community engagement. The international literature is, there's a lot of evidence that demonstrates the benefit of community engagement. Now it fits with Kaupapa Māori because it's focusing on partnership. The key aspect about engagement is that there is shared decision-making and shared communication, and community engagement ranges from low to high. The evidence demonstrates through a series of studies involving systematic reviews and meta-analyses that increased levels of community engagement results in enhanced capacity outcomes and health outcomes, and reduced, and there's some evidence moving towards showing that it reduces inequities, health inequities in a variety of communities, including Indigenous communities around the world. So the engagement element, it gets operationalized in different ways. Some people will call it participatory action research. Some people will call it community-based participatory research. They're consistent philosophies, different names, but generally consistent philosophy with the idea that we actively engage with the people we work with so that we co-create the work that we're doing, the intervention, with the idea that if people are involved, have ownership and determination of the intervention, it's more likely to be successful. The fourth element to our model is systems thinking. So systems thinking is a way of looking at the world that emphasizes the complexity and the multiple perspectives and relationships that exist in the world. So when we go to implement an intervention, when we do a research project or a randomized clinical trial in a limited setting, it's very easy to control how everything goes, but the real world doesn't work that way. The real world is complex. People have multiple influences. Within a given system, within a given community, there are multiple perspectives. So the systems thinking does emphasize these multiple perspectives, that there are different worldviews and values of how things get done, and that we need to emphasize these multiple worldviews because we identify multiple causes, multiple solutions as well. So it brings in that complexity and that multiple perspectives. It also emphasized that there are many relationships among not only organizations and people, but also in terms of ideas, and that these different ideas and influences create some complexity, and we need to understand those relationships. And the last aspect of systems thinking is the fact that there are multiple levels that we can intervene on. And Nina's going to talk in a few moments how we're applying all of these principles, but we'll give a clear example about multiple levels, that it involves individual people and affecting them, changing systems and changing the population as well. The final element to our framework is integrated knowledge translation. So integrated knowledge translation or transfer focuses on the idea that we are going to take, when we do an intervention, we're going to be asking, so whoever creates the intervention isn't always the people who deliver the intervention. What we argue and what the evidence shows in the literature is that when we work and co-create through a mutual learning process, an intervention with the end users, we're much more effective. So for example, if we're going to ask nurses to deliver dietary advice to patients who are pre-diabetic, it would be a really good idea to involve the nurses in that and how that's going to work, because they can help us identify potential pitfalls and barriers and enablers that would help us do this better. So there's this bi-directional process that basically, if we're going to ask people to deliver an intervention, these end users need to be a part about the creation and the process along the way. So that's our overall framework. What we have done with our framework is we developed a coding scheme to identify, and I'll illustrate this in a slide in just a moment, a coding scheme that illustrates what does it look like to do each of these elements at a high, medium, or low level. And we took our coding scheme and applied it to a study that looked at diabetes prevention in primary care settings in indigenous communities in Australia, New Zealand, Canada, and the US. 13 studies. And the conclusions of that systematic review was that a multifaceted intervention is more effective than a single level intervention. So it's supporting of that systems thinking idea. At the same time, they could not identify too much else in common about what made one intervention work versus another. What we argued is that our framework probably helps to illustrate why it works. So it's not so much what you do, it's how you do it. And that's what a key focus of our framework is. And what we did is code each of these studies. We had 2 independent coders code these studies for each of our elements: culture, centeredness, community engagement, systems, integrated knowledge transfer. And found that cultured centeredness and community engagement explain differences in diabetes outcomes, and community engagement explain differences in blood pressure outcomes. So we're looking at actual health outcomes. And even with only 13 studies, it's a very small sample size, so this is a pilot study and certainly not conclusive, we found that there is evidence that shows that when we do these things, how we do it, or in this case, how others did it, it really has an impact on health outcomes. So that process is very important. This is the framework itself. On an earlier slide, we had an email address that if you would like a copy of this poster, we can send it to you. Just drop us a note at hpwadmin@waikato.ac.nz. I know that this is a fairly small type, but basically what you can see on this is on the left-hand side is a definition of the elements of the the 4 key components that surround the ethos of Kaupapa Māori. And it demonstrates what it looks like if it's done at a high level, a medium level, or low level. And we also have a negative component. So it is possible to do something negative. For example, uncultured centeredness, reflexivity, if we blame the victims, we blame the people for their own problems rather than being reflexive about the complexity of the problems, that would actually be a negative level. Now, we didn't find any negatives in our studies. We had low, mediums, and highs, and some variability around that. So again, feel free to email us for this.
So we took, probably during the development of the framework and since we've developed it, we've tested it in a variety of settings, and we've shared it with lots of different organisations and people. And if you want a copy, there's an email, and we can send you the link. So we've used it in the Māori abdominal aortic aneurysm screening pilot, which got a 78% screening rate, wildly successful. And we're also developing a Māori breastfeeding intervention. With the 2 providers, Te Koho Health and Foote Trust, this framework informed every step of our partnership. So just to go through step by step what we've done with the providers. The first one is developing that partnership and that relationship. So the cultural centeredness and the community engagement is the first, and quite a long and engaged and iterative process. So even though we knew that it would take a while, it took longer than what we had planned for. So the systems thinking, we've done that with a couple of literature reviews, a systems map that Jeff has done, and also some case studies, a formal and an informal case study at the provider level, looking, from preventing the progression of diabetes, pre-diabetes to diabetes perspective. So that's where we are at the moment with the integrated knowledge transfer. So that's involving the people who will be implementing any intervention in the design of the intervention. So even though we haven't quite designed our interventions yet, we've got an idea of one intervention that we want to do, starting with a quick one, because it's, this thing's bigger than being here really. So we're working with some of the doctors and nurses and staff at the providers to identify issues and develop solutions. So this is a summary of some of the findings from our literature reviews, and I'll leave that for you to go back to. But here in more detail, we've got we've called it our Maunga model. So you can see at the peak of the Maunga, there's high impact interventions. In the highest impact intervention you could possibly think of is stomach stapling. That's going to have a big impact for the individuals involved, but there are going to only be a small amount of individuals, and it probably won't affect further down the Maunga, which is the whānau level. And then further down, which is an area that we're all really interested in, is the community level. So improving the food environment, and some of the stuff that we found from the literature is there is some evidence around this, but because, as you can see, the further down the Maunga you go, the more people you reach, but the smaller the intervention impact is, so the harder it is to prove efficacy of your intervention. And at the population level, poverty has a big impact, so anything that's going to reduce poverty. Then you've got things like sugar tax and GST, fruit and veggies. Some findings from our literature review are over here in the little blue boxes. And lifestyle interventions actually work. at the individual and the whānau level, and also at the service level. Collaborative goal setting works, and multifaceted interventions are more effective and are becoming more popular than interventions that are focused just on one thing, which makes sense because it's never just about one thing. So the literature found that actually there are multiple effective interventions for slowing progression from pre-diabetes to diabetes. How you do it makes a difference. So we coded the interventions against our framework. So interventions that use cultural centeredness, that use community engagement, had a systems approach, and that used integrated knowledge translation were effective. And given this, you think, well, why do we have such an epidemic of diabetes? It's going like this. And I think that's two reasons. One is the environment becoming more obesogenic, and two, not enough is being done to from the thousands of proven interventions out there. They aren't being implemented, and they aren't being implemented for the right communities and in the right way. So that's what we're hoping to address. Our framework appears to be well suited for solving these big so-called wicked problems, and it's even though it's quite new, it's also it's quite popular amongst the people that we've shared it with. I think you could say so. Please let us know if you'd like a copy, and we're open to questions.
And so you probably get a chance if you flip back and look at the slide that has the no, it's a long way back. Don't remember.
Okay.
Well, but the email, if you are interested in getting a copy of the framework, is hpwadmin@waikato.ac.nz. So hpwadmin@waikato.ac.nz. And just to kind of reiterate the conclusion is one of the important things is doing something. And I think one of the situations we're in at the moment is that people are becoming, well, actually funders are more and more interested in getting data to inform their funding decisions. And they're also, really interested in being able to demonstrate that the things they put in resources into are producing the sorts of outcomes that they're interested in. And I think there's going to be a real challenge for some of the providers in the future to be able to get the right sort of information to them to keep resources going through. Particularly because, when we do get back to that conclusion, doing something is the important bit. And we don't want to be in a situation where we're constantly measuring like the state which our community's in, and wondering why things aren't improving when we're actually not doing anything. So, I think it's really important that something's done. And what we've said is the how around it, how it's done is important. And a number of the principles that emerge from the kaupapa Māori space, we can make the argument that actually they're evident out of international literature and the international space as well. So I think our implementation framework is trying to pull those arguments together and make it easier for organisations to talk to funders about the importance of funding these kinds of activities. So, kia ora everyone. We will flip down through these, and happy to take any questions.
Excellent. Kia ora. Tēnā koutou. I'll take my headphones off. Tēnā koutou. I suppose just as a way of facilitating the question time, what I might do is I might read out these questions. The facilitators should be able to see these themselves, but I'll read this out, and then possibly the most appropriate or willing person can chime in to give an answer. So this is from Trevor Fredericks. And what practical measures will be implemented to make this model of care accessible to Māori and other culture groups?
In terms of practical measures that we can implement, part of what we're doing, what we're seeking to do is to identify a set of evaluation tools and practice guidelines that we then, that organizations, for example, could use. So part of this framework and the coding scheme does provide some practical sense of what this means. And through our continued work, we'll identify a set of questions, an evaluation framework that can be used to judge how well these 4 elements are being implemented, and that can be useful. You know, for example, if a community organization is partnering with some researchers, they might use those questions to guide their decisions about how to work with the researchers. So it'll be that evaluation framework which we're developing this year. And then the coding scheme that's on the back of this poster also gives you a sense of of what these concepts mean in practice too.
You know, we had a meeting yesterday and we were talking about this very thing around how do we get the information that we're kind of getting through this project and get it to different audiences, because you know, there's certainly an academic audience that is interested in what we're doing. There'll be sort of a policy agency audience that's interested, but also the community groups. And we need to present information in all different formats. So we've certainly been giving that some thought. The poster is one of the ways that we're trying to make information accessible to community groups as we're going through, and give them something which they can start talking to maybe people that are involved with funding their services, some ways of engaging in that conversation. In the process of putting together a policy brief, which would probably have a little bit, you know, be a little bit more in depth, talk to some of the findings we've had around the systems map. And what I might do is just kick it over to Jeff to talk a little bit about what the focus of that component of the project was. Is that a good segue, Jeff?
Yeah, that's a great segue, Maui. Thanks for that. So the systems map was really an attempt to look at how stakeholders are responding to the issue of pre-diabetes. And so it was a way at looking at some of those key perspectives, relationships and levels to really help to think through, well, what are some of the opportunities and what are some of the barriers? So it provides a big picture look at some of the drivers for pre-diabetes, describes the ways in which some of the different actors from policy to practice are attempting to address pre-diabetes. And also, given the fact that the world is a complex place, it also shows how some of the good intentions can be sometimes undermined by some of the system dynamics. And also the system map looks at some of the uncertainties people are dealing with, given that pre-diabetes is an issue we really don't have a good handle on at the moment.
I think this provides quite a different way of working for a lot of providers. So my job as part of the team is to get our framework to be used by people like the Ministry of Health and District Health Boards. So, and I think, you know, it is quite a different way of working, but I think because it's all laid out quite clearly, it's quite easy to follow. Actually, developing the relationships and the reflexivity and allowing that community voice, whoever the community is, but the community is defined as the group that you're working with. It may be a community that's geographically defined or culturally defined, and integrated knowledge translation, I think, is something that makes intuitive sense, but now that it's laid out clearly, I think it'll be, it's going to be quite easy to pick up.
I've also noticed that we have a question from Jane. Says we see it as being a really useful way to address issues of gout, how do we go about developing a relationship from Arthritis New Zealand? This is one of the, I guess, the challenges of doing any community engaged work is finding the partners. Jeff talked a little bit about stakeholders and the importance of stakeholder analysis and making sure that we're engaged with the right people. We also are hoping that by providing the evidence that engagement works, that cultured centeredness works, that integrated knowledge transfer works, that also helps provide you a segue to developing some of those relationships that can enable you to go to Arthritis New Zealand, for example, Jane, and say, I've just heard this presentation, here's what I found out, and we'd really like to engage in a partnership. What do you think? So that's kind of, we think this information, just this poster itself, might be a useful way to start a conversation and just explain why you think it's going to be beneficial. So that would be my approach to that question.
And we're happy to help with any kind of anything.
Yeah, absolutely. If we can be of help, please let us know.
We've got a team with lots of different expertise, and we want to evaluate how the framework's being used in real life. So if you do want to use it and you want some help with it, please let us know, because that'll be good for us too.
Now, I see that we have another question as well. Again, community participation is imperative to embrace change. How will this process be rolled out for people to embrace? Well, I'm going to put the question out for our team. See if like to. I have to answer.
Yeah, so in some ways, I think the answer to this question is a little bit like probably the last one. Is there's a lot of politics involved in who gets to be parts of conversations, and that shifts from, that shifts over time. So at some points in time, you may feel like you're kind of engaged with the system, and they're taking notice of you, and then things change, and then all of a sudden, your voice isn't valued as much as they have been in the past. And I'm one of the directors on our iwi Health and Social Services. I understand that probably in a similar way to a number of you that are listening as well, and we certainly have our own struggles with that. I think it's going to be more and more important for us to be able to talk about what is the evidence about what we do. I mean, and what I mean by that is, as the system moves towards collecting data from across the whole thing and using that to inform decisions, they're going to tell us what our story is. And we need to be in a position to say, actually, look, here's the information that we've been getting out of our service, and this is what our story is. And that's going to be a really important part to ensuring that you can get into a different sort of conversation. I think in terms of the implementation framework, it's about trying to make an argument to the funders as well about the importance of staying involved as a community group in the conversation. The key message out of this is that actually any intervention that's chosen to be done is probably going to have an effect. If you then do it in a way that takes into account these principles and does get the community engaged and thinks about how culture fits in the middle of that conversation, it's likely to be more effective. So I think there'll be a component around how an organisation might be able to adopt this and talk to the funders about how they get resources to support some of these activities as being part of supporting the development of a culture of quality improvement, but also in terms of ensuring that there are better outcomes from the services that they're funding.
I think in response to the question also, how are we going to get it out there? We're just going to take it to as many places as we can. So Pride Up next week, we'll be taking some posters there, but and publishing and you know, having discussions with as many people as possible.
Okay, so there's another question here. There seems to be quite a few people from all cultures with comorbidities. Will they be included in this model of care?
So I can do that. So our model of care is focused. It's Māori focused, so kaupapa Māori centred, which is Māori focused by definition. But anything that works for Māori is, I think it is transferable to other groups. But I think the key part of our model is that it's, you know, it has that indigenous focus. Yeah, so I'd want to keep that. But you could use the model, the principles. So, for example, with methods for preventing progression from pre-diabetes to diabetes. So, with any interventions that we develop up around that could, I'd say that they're also likely to work for other ethnic groups.
But I mean, it's also other contexts as well. So thinking about, you know, Nina's already applied it for breast screening and for breastfeeding and aortic screening.
Yeah.
So it's non-specific in that sense, and it's, you know, certainly would be useful in the context of comorbidities. You know, we think for our National Science Challenge project, the focus has been trying to work with groups around developing interventions around that pre-diabetes to diabetes space. But it's likely that interventions that are developed in that arena are also going to have some usefulness for other conditions. And a number of people that will have comorbidities which have to be dealt with. So it's not, I guess, disease-centric in that sense. And it's probably not, it's not at a model of care stage at the moment. It's certainly principles and a framework, but the activities that are going on with each of the two community groups, with HPW Trust and Te Kōpao Health, may eventually develop into something more akin to a model of care. And, you know, certainly would be happy to share that as that develops.
I mean, I'd like to see it inform the rollout of the National Bowel Cancer Screening Program. So use the framework, which is Māori centred, to inform how the program's rolled out at district health board level. And that would be for all ethnic groups, but it would start off from a Māori focus. I think it's transferable to many different situations.
Yeah. Can I just make one comment about the transferability? I think all the elements in the framework really draw attention to the importance of context and the absolute criticality of getting alignment between a service and a person who may use a service. And so it's that alignment which is necessary to achieve that co-creation of value. And I think at a principle level, I think that does extend and transfer to other ethnicities. And as Maui and Niwa were saying, also looking at it from a common risk factor approach, thinking about other chronic conditions.
Kanawe. Well, we don't seem to have any more questions streaming through. I think that everything that was rather comprehensively covered. So I'm going to close it off for now. If you have any further questions, you can definitely keep them coming through. If you have moments that you kind of ponder on after this and want to reconnect, you can do that as well. The easiest way is probably to connect through to Tangata, and we'll make sure that you get through to the right place. But before that, he tuku mihi tēnei kia koutou. This is an acknowledgement to you guys from the team Nā te reto hoki o tēnei momo anga rangahau is a really grand acknowledgement of the depth and wealth of understanding from multiple participants to a really comprehensive framework that I'm sure will be applied and can be consolidated from an evaluative process. So thank you very much to everybody involved. Have a fantastic Wednesday and see you next time for another webinar. Haere rā.